There are currently 8 biologics that are available to treat allergic diseases. These allergic diseases include, and honestly, this sounds like a Harry Potter spell. Are you ready for it? They include asthma, atopic dermatitis, chronic spontaneous urticaria, chronic rhinosinusitis with nasal polyps, food allergies, eosinophilic esophagitis, prurigo nodularis, eosinophilic granulomatosis with polyangiitis, and hypereosinophilic syndrome. Yep, it sounds like a lot. And we are going to be unpacking the biologics that are treating those conditions. We have a great guest who's joining us to unpack how each one of the biologics works, what part of the immune system they're turning off, and which conditions they're treating. This podcast is made in partnership with the Allergy and Asthma Network, and we want to thank Sanofi Regeneron for sponsoring this episode. While they support the show, all opinions are our own, and sponsorship doesn't influence our content or editorial decisions. Any mention of brands is for informational purposes only and not an endorsement. Are you ready? Let's get to those 8 biologics. You're listening to The Itch, a podcast exploring all things allergy, asthma, and immunology. Today, we are diving into the biologics that are approved for allergic conditions. This is going to be a wicked episode. It's going to be interesting if you're like a science geek or you're just intrigued anyways by how much is going on in the medical world that you might not even know about. But basically, we're going to be talking about 7 different biologics. There's an 8th biologic that just got approved in mid-September. So we're going to unpack all of the different biologics that are on the market and what conditions they're approved for. But first, we want to introduce our guest, Dr. Permaul. Dr. Permaul, welcome. Can you tell us a little bit about who you are and why you're joining us to unpack these biologics?
Hi, so yes, I'm Dr. Perdita Permaul. I'm Section Chief of Pediatric Allergy and Immunology at Weill Cornell Medicine. And in addition to my clinical duties, I'm also a physician scientist with my main area of interest being childhood asthma and how environmental exposures affect their asthma, but also looking for biomarkers or mediators or messengers, as we're going to be talking about, to target to help improve a child's asthma. So this is why this is a topic that I'm very happy to speak on.
So let's jump into it. I'm going to caveat this with saying, and I think that if you've listened to our other biologics episodes, you'll know I'm saying this often, is that biologics names are crazy. And they're super hard to pronounce, and I think it can get a little bit confusing for patients. So we're going to introduce both the biologic medication name and the brand name, so the name that probably you've heard of more often. And I don't think we're going to interchange them much. We're going to introduce both names and probably stick to the brand name just because that's going to be like way easier to follow. So that's just one little thing before we actually get into it. And now with that, let's actually get into it. So we're going to go chronologically. Dr. Permaul, what was the first biologic that was approved for allergic conditions?
So the first one that was approved is Xolair. And Xolair has been approved for allergic asthma. That was the first one. It was approved in 2003 for moderate to severe allergic asthma. And then it was approved for chronic idiopathic urticaria, also known as chronic hives, in 2014. And then in 2020, it was also approved for chronic rhinosinusitis with nasal polyps. And what is that? So that is a condition where the inside of your nose and the sinuses, which are the spaces surrounding your nasal cavity, they get swollen, they can get irritated for a long period of time. And because of that, you can get something that's called nasal polyps. And so nasal polyps are really soft, jelly-like, glistening bumps that can grow inside your nose and in your sinus passages because of this swelling. And that's what Xolair has been approved for. And now, most recently, February 2024, Xolair was approved to prevent reactions due to food. So if you are a food allergy patient, this is now on the market to help prevent anaphylaxis, which is the life-threatening food allergic reaction.
So Perdita, can you tell us also about how exactly Xolair works? So what is it doing in the body? Because I know that when it first got approved, a lot of allergists were like, oh, okay, this is what it does. That means that we're never going to have to use any other medications, and we basically cured allergic disease. So can you tell us a little bit about how does it exactly work?
Yes. So you're correct, Kyle. When Xolair came on the market, we thought that it was going to be the cure-all for everything. And what we found is that no, that our immune system is more complicated than we think. There are many complex immune pathways, in allergic diseases. And so targeting one molecule, which we're going to talk about, the IgE molecule, that's how Xolair works, may not be the cure-all for all. That there might be messengers or chemicals further upstream or further downstream that we need to target. And that's why there are so many biologics now on the market. Specifically, when we're talking about Xolair, what does Xolair do? So Xolair binds or targets something called immunoglobulin E, also known as IgE. So we're going to call it IgE moving forward. And IgE floats in your bloodstream. It is our allergic antibody that triggers an allergic response. So when you come into contact with something that you're allergic to, whether it's pollen, dust, animal, standard food, what happens is that specific IgE that your body has made to that allergen causes cells in your body to release chemicals. Histamine being one of them. So that is why we take antihistamines. It blocks the chemicals IgE releases. There are other mediators that also get released, such as leukotrienes and tryptase, to name a few others. So what do these chemicals do? When they get released, they cause itching, they cause hives, they can cause swelling, trouble breathing. And so Xolair targets and binds to the IgE and prevents this from happening.
Thank you. Yeah, I think that a lot of allergists, as you said, thought that this was going to be the cure-all, and it wasn't, because there are so many other mediators that can jump in and start causing that inflammation in so many different conditions. And that's why we have so many other biologics. So can you tell us about the next biologic that was approved?
So the next biologic that was approved is something called Omalizumab. Brand name is Nucala. So what does Nucala do? Nucala is a medication that targets another cell that is important in the allergic response, and that is the eosinophil. Eosinophils are special white blood cells in your body that are supposed to help fight germs, such as parasites. But in certain people, it causes allergic responses. And so Nucala blocks an immune mediator or a chemical called interleukin 5 or IL-5. And what does IL-5 do? So IL-5 is responsible for helping the eosinophil grow, mature. It activates the eosinophils to move from the blood into the lungs. So that's why we have lung inflammation and asthma. And we call this kind of asthma eosinophilic asthma. So in summary, blocking the IL-5 stops the eosinophils from growing and maturing. And think of all of these medications as switches, right? So if we turn off the IL-5 switch, that causes the eosinophils to grow, then we're going to have less eosinophils, which means less swelling in that area of the body.
Yeah, I love thinking about the switch analogy when we talk about biologics, especially since we're going to be talking about all of them, and they're all just responsible for a different switch, right? Which is like a different part of the immune system. So going back to Nucala, we didn't talk about, but what has Nucala been approved for?
So Nucala was first approved in 2015 for eosinophilic asthma, which is a type of asthma that I told you has to do with eosinophils going into your airways and causing inflammation that way. And as physicians, we often send off a routine blood test called the CBC. The CBC can tell us what your eosinophil count is. And based on that, we can decide whether or not Nucala might be a good medication for you. The other thing that it was approved for in 2017 was something called eosinophilic granulomatosis with polyangiitis. EGPA, a mouthful, I know. But it is a condition where the eosinophils cause swelling in the different parts of the body, including the lungs, the skin, even the blood vessels. And then in 2020, it was approved for another condition called hypereosinophilic syndrome. And it's exactly what it says, hyper, or excessive eosinophils, extra eosinophils that are building up in places like your skin, your lungs, your heart, other organs, and also causing inflammation and damage. And then the last indication was approved in 2021 for chronic rhinosinusitis with nasal polyposis. So similar to Xolair, it is now approved for chronic rhinosinusitis.
So we've just talked about two. We've talked about Xolair and we've talked about Nucala, and both of them have been approved for multiple conditions. I'm curious as to how we figure that out, because Xolair was approved and then only 10 years later was it approved for the next condition. So what is it that indicates that you can approve it for multiple things?
Great question, Courtney. This is one of the reasons I love medicine so much. Biologic medications help us understand diseases better, for sure. We've learned one part of the immune system might not work for everyone, but sometimes the same medicine can help with different diseases. And we often figure this out when real patients are given the medication and we see that it's helping with other diseases. The issue is, though, that it takes a long time to get a medicine approved for something new because it has to go through rigorous clinical trials and you have to study it carefully to make sure that it works for that specific condition. But it's just basically trial and error and starting a patient on a medication and seeing how it works in that patient, especially a patient that has multiple atopic diseases or allergic diseases.
Yeah, so it's really paying attention to our patients and realizing that a medication that we started for X condition is actually now helping for their other condition. And that's what we realize over many, many years is that we really need to pay attention and see where else are we seeing improvements. And then if we see that across the board for multiple patients, that's when then a medication starts going into a trial and they start looking at it for other conditions. And we'll see that as a pattern for a lot of these, as you noticed for the first two.
So is it that all doctors are reporting these trends, or how does that happen? So if I talk to my doctor and I tell them, oh, this is improving, this is improving, this is improving in my life, are they then reporting that? How does that look? So that patients can also note what they should be telling their doctors on top of just like feeling better for what they're being treated for.
So I know at least for Xolair, the way that got approved for chronic hives is that there was a patient that came into clinic who also had asthma and was on Xolair, but also had chronic hives. And it was noted that the patient's hives got better. And so they put a case report together and published it showing this. And that sparked the research interest. And then that's when the clinical trials started. So I think it's both the patient, but also the physician who has to keep track of how the patient is doing symptomatically.
Yeah. And we need research scientists like Perdita that are wanting to be in that space and wanting to do the research, because doing research is not easy. It actually takes a lot of time, a lot of work. It's a lot of detail-oriented work, and it's not always easy. And sometimes you can do research for many, many years on something that you think is going to be helpful, and then it ends up not showing the results that you thought you were going to see. So it really does take a lot of people being interested in moving the needle and moving things in the right direction for us to have all of this movement. And also why I love medicine so much, because we're constantly learning, we're constantly changing the way that we can help patients.
And the one thing also as a pediatric researcher, a plug, is a lot of these medications get approved first for adults. And then you have to wait and wait for it to be approved for children. Understandably so, because we want to be careful with children. Their immune systems are naive and they have other parts of the immune system that we need to keep track of that are different than adults. And so that we have to do rigorous trials for children as well. But this is why it's important to do the research in pediatrics as well, because they also need to be taken care of.
Absolutely. I think doing research in pediatric population is even more hard because parents are as likely to put their kids into trials. It's not easy to get a medication approved in that age group. So thank you for all the work that you're doing, Perdita. We appreciate you.
And I appreciate all the patients and parents who enroll their children in our studies, because it's very helpful to move the needle, as you say.
And also, just as an adult, I enroll myself. I generally don't get accepted, but I enroll myself in all the studies that have been in Berlin. I just email them. I'm like, is there anything open? What can I help with? Because I feel like that's the one thing I can do to give back to the community if I'm taking a certain medication. And I'm like, just observe me anyways. Why not? So I always like to put myself out as a guinea pig. I think it's a good way to give back. So moving on, because we've only covered a few and we've got quite a list to go through. What is the next biologic that was approved after Nucala?
So after Nucala in 2016, there was another medication, biologic, that was approved for eosinophilic asthma, and it's called Syncare. And Syncare works similarly by binding to IL-5 or attaching to interleukin-5, which then stops interleukin-5 from working. And as I said, the IL-5 is needed for the maturation, the growth of the eosinophils, the activity of the eosinophils. And again, we don't want too many eosinophils where they should not be, namely the lung. So Syncare blocks the swelling from occurring in the lungs for people with asthma.
And is Syncare approved for only eosinophilic asthma?
Yes, so it is only approved for eosinophilic asthma. The one thing I will say about it, though, is that it is the only biologic for eosinophilic asthma that requires intravenous administration, which means that every time you administer it, you have to put an IV in. Now, many of these biologics can now be given at home and not in the office. So now in medicine, we do a lot of shared decision-making with the families, whether or not they want to take the medications at home, how often do they want this medicine to be given, monthly, every 2 weeks, because the dosing schedule is different for every biologic and for every disease that we're giving it for. So I think that with all the options that are available at this time, people are opting for the medications that are not being given intravenously. So I think Sincare is a great medication, but probably would be best in inpatient sort of situation where IVs are easily placed.
Yeah, absolutely. I think that's why it didn't really take hold as much, because having to go in to get it and having an IV placed can be a bigger deal than just using an injection, a needle that can go into a fatty area and be injected. So it is definitely a different administration. The next one we had was benralizumab in 2017, which is called Fasenra. How does Fasenra work? Because I also know that it targets IL-5.
So Fasenra, correct, is anti-IL-5, you can say medication. It also is targeting eosinophilic asthmatics, that is their patient population. However, Fasenra works a little bit differently. So instead of binding to the IL-5 itself, that molecule in the blood, it's actually targeting or attaching to the IL-5 receptor. So the IL-5 receptor, here's your IL-5, here's your receptor, they bind, and then boom, the whole cascade happens. So instead of binding to the IL-5, Fasenra is binding to the receptor so that the IL-5 itself cannot bind to the receptor. In actuality, it's doing the same thing, because you're still preventing the maturation and the activation and the growth of the eosinophils, but it's just where it's binding is different. In the end, it's leading to less inflammation and swelling in the airway.
Great. So just to clarify, it sounds like all of these biologics that we've talked about, besides Xolair, which is IgE, but all of the IL-5 medications that we've discussed, they're all doing something different with IL-5. So their switches are all in different places, but they're all switching off IL-5 in their own different way.
Right. And then affecting the eosinophil.
Great. And we'll have a cheat sheet in our show notes in case anyone wants to follow along and be like, so that's the switch there and that's the switch there, because it can sound a little bit confusing, but just to understand that, like, the IL-5 is responsible for eosinophils, right? So those two things we're talking about together.
Exactly.
And Fasenra, what has that been approved for?
Fasenra at this time is only approved for eosinophilic asthma. So now we have Sincare and Fasenra that are only approved for eosinophilic asthma, but then we have the Nucala, again, an anti-IL-5 anti-eosinophil medication that is approved not just for eosinophilic asthma, but also for this hypereosinophilic syndrome and this EGPA. I'm not going to say the full name, but yes, so other diseases as well that Nucala can touch.
Yeah, I would say from like 2015 onwards, then it really started to spiral, right? And then we really started to see a lot more biologics come out. And then the next one that came out was right after Fasenra, and that was dupilumab or Dupixent in 2017 for eczema. And that was the first indication in which Dupixent was approved. But can you talk about how dupilumab works, Perdita? Because it is very different from the ones that we've spoken about so far.
I don't work for any of these pharmaceutical companies, but I will say that Dupixent has been a real game changer, especially for our little babies who have really bad eczema or moderate to severe eczema babies with tons of food allergies. No matter what topical steroids you give them, they're not getting better. So Dupixent was first approved in 2017 for atopic dermatitis, also known as eczema. How does it work? It works by binding, targeting two other interleukins. So we've talked about IL-5. Now we're going to talk about interleukin-4 and interleukin-13. Those are the two messengers that this medication binds. And they both lead to swelling. So how does that work? When Dupixent blocks these messengers, it calms down the immune system, it reduces swelling. Now we know that IL-4 is needed for the production of IgE. And what did we say IgE was? IgE is your allergic antibody. So it binds to IL-4. And if you don't have IL-4, then you're not going to make this allergic antibody. And this is a perfect example of how targeting mediators further upstream is helping with diseases. So we're not blocking the IgE, we're blocking the IL-4, which is further upstream. We also know that IL-13 can cause eosinophil swelling and inflammation as well by releasing other messengers to activate the eosinophil. So in that way, we believe it works as well. Dupixent was also then approved in 2018 for asthma. And then in 2019 for chronic rhinosinusitis with nasal polyposis. And lastly, in 2022, which has also been a great game changer for us. It was approved for a disease called eosinophilic esophagitis, where we intersect with our gastroenterology colleagues, very much so, and for another skin disease called prurigo nodularis. And so you can see here that there are many, many indications now for Dupixent, down to age 6 months for eczema, down to age 6 for asthma in children, and even down to age 1 for eosinophilic esophagitis now as well. So the age keeps moving further and further lower, younger, younger, and younger, which is also great.
Yeah, as they do more studies, then the age group just goes lower and lower, because when it was first approved for eczema in 2017, it was, I do believe, 12 and older. And then the age just gradually went down, which I was so excited about because, as you said, Perdita, these kids really suffer from eczema, and it's really hard to see it, and it can really affect their behavior. It can affect their development in drastic ways. And so having that, I really do believe, was a game changer. And I was really happy about that when that happened. And so now we're all the way up to 2021. We had the approval for tezepelumab, or Tezspire, or Tezzy, as many people call it. And that was approved for asthma. So can you tell us a little bit about how Tezzy works?
So Tezspire is an interesting medication. We were really excited about this one when it was approved, because this biologic for asthma does not require any specific blood test. It doesn't require a specific cutoff number for eosinophil count or for an IgE level for us to prescribe it. Truthfully, we think that this medication can be given for all types of asthma, because we know that asthma is not just one type of asthma. There's many different types of asthma. And so the way it works is by blocking something called thymic stromal lymphopoietin, or TSLP for short. And again, like all of the other immune mediators, when you block it, we will have a decrease in inflammation in the airways. And so this is also a medication that we're wondering, could this help with the obesity-related asthma phenotype, which is an area of research that I'm looking at, childhood obesity and asthma. Because again, it's not looking for an allergic kind of phenotype or presentation like an IgE or a high eosinophil count. And we know that obese people who have asthma have a different kind of asthma as well. That's not necessarily allergic in nature. So can Tezspire help these patients? So it is approved down to age 12, I believe. It's fairly new on the market, and we'll see how it does in our asthmatics.
What's interesting is that the newer medications that are coming up are only approved. So I know that Tezzy is only approved, you said, for asthma, which is interesting. And I know that the next one we're going to talk to is only approved for one thing. And like you guys had talked about earlier, is that with time, we see that more disease states are getting approved for these medications. So it'll be interesting when we do this again in 5 years, what Tezzy might also be approved for, since you mentioned you guys were really excited about what it does. So talking about that, what is the next one? And I'll let you pronounce the biologic name because I refuse to.
So this one was approved in 2022 for atopic dermatitis or eczema, and it's called tralokinumab. Tralokinumab is also known as aEbglyss, which is the brand name, and this blocks just IL-13. So as we said with Dupixent is blocking two things, IL-4 and IL-13. Tralokinumab or aEbglyss is blocking just IL-13. And as we mentioned, IL-13 might have a role in eosinophil inflammation, and so it helps to calm down the immune system, reduce swelling, and for this particular disease, eczema, it's helping the skin to heal.
So like we talked about with the IL-5 medications, it's all kind of being turned off in a different way. And Dupixent is targeting 2, whereas aEbglyss is only targeting 1, which is the IL-13. Why would you choose a medication that's only targeting 1 as opposed to 2? Because isn't 2 better than 1?
I can say with atopic dermatitis in particular, when we use a medication like dupilumab, one of the side effects is potential side effects. Not everyone gets it, but is that conjunctivitis or the itching of the eyes. And I don't know if we've seen that really with aEbglyss. So, sometimes people will respond to one medication better than the other. And so it's really just good to have options. And so if for whatever reason the person didn't respond to dupilumab because they ended up having this more rare side effect of the itching of the eyes, then we have an alternative to use with the aEbglyss. And so I really love having options. So you might think, oh, we're only blocking one thing and here we're blocking 2 things, so we should always use this medication. But that's not always the case because, as Perdita said, sometimes different patients will react to different medications in different ways.
And the other thing I wanted to point out also is looking at the patient and knowing, okay, this patient has asthma and the patient has eosinophilic esophagitis. What might be the best biologic for that patient? Dupixent might be the best because it's targeting both diseases, right? Then I also told you the dosing is different. Some patients might not want to get dosing every 2 weeks. Maybe they just want, for instance, Fasenra. Fasenra can be given once you've done the loading dose. You can get it every 8 weeks. So a shot every 8 weeks might be more attractive to a patient than getting a shot monthly. So these are all the things. And yes, as Paula says, we have so many options now that we can sit down and discuss these things with the patient and come up with a plan for them that works best. And if one doesn't work, then we can always switch to another. That's the other beauty of it now.
Yeah, as a patient, that's really exciting. I just started a biologic, as everyone has probably learned, because that's all I talk about in the last few episodes. But I just started Dupixent, and a lot of what you guys are talking about is exactly how we chose why I wanted to go on Dupixent, is that I'm primarily being treated for atopic dermatitis, but I also have asthma. And so that seemed like a pretty natural first step for me. So, and it's exciting to hear that there are options, because if, say, Dupixent isn't going to work for me in a couple of months, then I can go back to my doctor and talk to him about what else could we try. So that's a really reassuring thing to hear. And honestly, I never really considered anything else but Dupixent, because that was always what I was told was I was going to go on. But now with Adbry and others, there's more options for atopic dermatitis.
Then the other thing we should talk about, which I don't like to talk about, is also insurance coverage, right? Because these medications are very expensive. You need insurance to cover these medications. And so that is the other thing you have to take into consideration. Will the insurance cover one biologic over the other? Discussion to have with your doctor. But this is such a great time now, the era of biologics. I remember when I was a fellow in training in allergy and immunology, we just had Xolair. That was it. We had Xolair. And to see where we've come in the past 10 years is just remarkable, I think.
It really is. It's just moving so fast. Knowledge and everything that we're learning is moving really fast. And it is exciting for the way that we can practice medicine and everything that we can offer. And speaking of, there's actually one that just got approved in September 2024. So right now, Perdita, can you tell us a little bit about the new one that was just approved?
Yeah, so very recently, fresh off the press, we have lebrikizumab. Lebrikizumab is also an anti-IL-13, and it was approved again for the indication of atopic dermatitis. So it seems that IL-13 might be an important mediator in the eczema disease. We'll see how this works for our eczema patients.
Wonderful. Well, thank you so much, Perdita, for taking the time out of your super busy day. I know you're a busy mom, a busy researcher, a busy clinician, but I knew because Perdita and I actually work with the New York Allergy and Asthma Society, and we're both board members. And I knew that you should be on this podcast because you're just so smart and so passionate about what you do. And I look forward to actually doing more episodes with you and talking more in depth about everything that you do with childhood asthma.
Thank you so much for inviting me. This was really great.
Yeah, thank you so much for holding our hand through this epic biologics episode. I hope that everyone has learned something, but again, it'll be interesting to see what happens in like 5 years. What this podcast episode will be in 5 years remains to be seen.
Thank you for listening to today's episode. Remember that all information you hear today is for informational purposes only and are not intended to serve as a substitute for the consultation, diagnosis, and/or medical treatment of a qualified physician or healthcare provider. And also, don't forget to subscribe to our podcast. And if you have a second, help spread the word by rating our podcast and sharing with your friends and family who might also be interested in learning more about allergies, asthma, and immunology. You can always stay up to date by checking out our Instagram, The Itch Podcast, where you can leave questions you are itching to know, or check out our website, which is www.itchpodcast.com, which contains more information about the subjects we covered in today's episode and every episode. Until next time, have a fabulous week.